So thank you very much, Richard, for the opportunity to talk to you. As Richard said, I'm a doctor by professional background, worked at the Department of Health, worked at the World Health Organization, and have also worked in the private sector. And for the last 15 years or so, I've been championing the links between health and climate change. And what we do as a Sustainable Healthcare Coalition is bring people together for action. And we bridge the public and private sectors. Who are we? Well, we're a partnership of healthcare companies and health agencies, and we were brought together by the NHS's Sustainable Development Unit when, as Richard said, they did their initial calculations on the carbon footprint and worked out that a lot of the stuff that the NHS produces is actually related to private sector production. So when they looked at that, they worked out that about 30% of the NHS's carbon footprint was actually related to medicines and technology devices. And what they really wanted to do was to solve this problem with the people who were producing it. So David Pension and colleagues had a very smart idea at the time, which was to bring private sector companies together to really look at how they could work out the carbon footprint of products and devices. At the time, this was actually the first time anybody had looked at the footprint of medicines and devices globally. So together, we produced the first carbon footprinting guidance with the help of Michael and colleagues at ERM. Of course, as many of you will have guessed from your own clinical work, is that just knowing what a medicine or a device does isn't enough. And people's realization was that, of course, you need to embed that into a care pathway. You need to understand how a patient moves through the system. So we developed that work further by then chunking care pathways into the parts of primary care, patient travel, inpatient stay. And Michael's going to talk more about our work. But at the heart of this is really the notion that if you can't measure something, you can't manage it. And once you begin to understand where your impact is, then of course you can move things on. So the guidance is freely available. It's there on our website for people to use. And it's really designed to do two things. One, as a design challenge if you're starting afresh, which not many people have the opportunity to do with care pathways, but also to really think about how you optimize existing ones. And because we're very keen to get people to think around how to use those metrics, how can you do the calculations to understand the impact you're having, in the last year we've just developed and just launched our online care calculator, which takes that pathway guidance and really gives people the opportunity to do, if you like, some quick and dirty digital equivalent of a back of an envelope calculation to look at where your care pathway might have a hotspot and what you can do to change it. We've also produced, as a result of this work, a number of case studies with the companies that we work with. So from knee replacements, looking at how apps can reduce demand on the healthcare system in terms of getting people ready for surgery and afterwards, in designing with clinicians renal care pathways, with AstraZeneca and again respiratory physicians looking at smart inhalers, and then with diabetes care. And each of these have been predicated on the fact that if you take a real world problem and that you try to look at how you measure it, then you can design together a better solution. And during the pandemic, and obviously before, one of the things that we've been interested in is the power of digital health. And we have all seen, and you don't need me to tell you, that digital has transformed delivery in the last year. What I think hasn't been so much in the narrative, and I think we should really be focusing on, is not only that that might improve patient outcomes and reduce cost of delivery, but very importantly, part of how we need to think of quality of care going forward is its environmental impact. And what we're beginning to do is work on a number of case studies to look at why that is true, but really bring again to people's consciousness that digital is good for a number of reasons and it's good for the planet as well. So As a coalition, as you can see, we've done a number of things over time. Together as a group, we've worked with the STU on developing thought leadership pieces, for example, on the circular economy. And some of our members are beginning to bring forward products that actually embody that. We've also looked with colleagues in the NHS, both in England and Scotland, around, how do we move things on with the supply chain and procurement? And we know at the moment that there isn't enough happening to bring people into a conversation, and that actually at the moment, environment doesn't matter enough in the system. So part of our passion is to try to build environmental impact into all the rules. So we've been working with NICE in the last year to look at how we might do that in terms of how they assess medical devices and advising them on how they can really challenge companies to go further on this and the reality of how they can think about it in the best way. We've also been focusing on, as so have so many, on plastics, and in particular single use, and we've been looking at priority categories based again on what the NHS Sustainable Development Unit tells us are the most likely categories of plastics to be used in the system, and then worked with our companies to examine that in depth. We're also, as Michael will tell you, working with a number of colleagues in the NHS looking at care pathways. We're doing some work with Newcastle at the moment, looking at renal care pathways in detail. So at the heart of this is that we understand if we want to change the system, that I think, as Michael will go on to remind us, that we need to take lots of actions. That's why what all of you are doing in the colleges and the opportunities for us to collaborate together is so important, because innovation and examples of what works and working together to prove that measurement can make a difference, to prove that improving impact on the environment can also improve clinical outcomes, are just so important in driving change. So just to kind of finish before I hand over to Michael on the fact that clearly we welcome opportunities to collaborate and to really understand what the barriers to change are. And as Tom will come on to eloquently describe later, there's been so much that the anaesthetists have done in terms of trying to break down what we can change. And we love working with people to bring companies in to try to solve the problems and challenge the companies on how they need to change. So Richard, that was really all I wanted to say. We're open to lots of conversations, and just to thank you for inviting us today, but also to thank you also for bringing us together as health organisations, because we're beginning to collaborate in ways that we didn't before, and joining up across the system and collaborating is exactly what we have to do. So thank you very much.
Right, well, thank you, Fiona, and you'll have opportunity to ask Fiona questions at the end of the 3 presentations. So, Michael, can we go straight on to you?
You certainly can. Can we see my slides?
Not yet. Maybe they're about to...
Oh, how about now?
See, here we go.
Yeah. Apologies, technology isn't my strong point. Right, well, thank you, Fiona, for setting me up, and Nikki and Richard for the invite to talk today. Just to give you a bit of background, I've been appraising the environmental impact of products and services and companies for 25 years. And I'm slowly, I'm not sure there's many sectors I haven't worked in or appraised, or product systems, that type of stuff. But it's about 8 years ago that I started working with the NHS and the Sustainable Healthcare Coalition, which was previously called the Coalition for Sustainable Pharmaceuticals and Medical Devices. So you'll see some of our documents are called that. And I'd say that's been a really inspiring last 8 years that I've been working. I mean, I've never known such a group of individuals who are so inspired to actually make change. And I guess it's partly because you see the effects of poor environment on the patients you actually have to treat. But what I'm going to talk about today, this afternoon, primarily is about how you go about appraising the sustainability of clinical care pathways. As Fiona said, the guidance was developed back in 2015. It was essentially developed and led by the NHS, SDU, and 30 other organisations, which essentially came together from across the health areas of healthcare. The coalition members obviously put finances in to support its development, but it was very much developed from a clinician's point of view and not from the sustainability experts' point of angle. And so it's very much for the layman to be able to pick up the guidance, sit down, work through it, and be able to appraise a clinical care pathway. It uses life cycle assessment approaches. It's built on the international standards for life cycle assessment and the greenhouse gas protocols. And the reason why, I mean, Richard alluded to it, is the reason why we have to take a life cycle approach is that, you know, over 50% of the impact of the health and social care activities in the UK is associated with activities upstream and downstream of the actual clinical activity. You know, it's not about your direct energy use, or a contribution is. It's not about your direct energy use or your emissions necessarily of non-anesthetic gases. Actually, I think it's 57% of the footprint comes from the rest of the supply chain, both up and downstream. And that's why life cycle approaches are needed when appraising care pathways. The guidance provides, like I say, practical step-by-step guidance. And so what are those steps? So how do you go about appraising a care pathway? It's not life cycle assessments. It's not rocket science. Nobody should be afraid of having a go at this. There's no dark arts here. The first step is essentially to define what a clinical care pathway is. What is it you want to report your results against? Is it against a single type of patient, or is it a patient population? What was the time period you're talking about? That's the first step. The next step is sort of the interesting bit, I would say, and the most informative is around developing a detailed map of the activities and interventions associated with a clinical care pathway. And what we mean by that is pretty much everything that goes on as that's associated with the care pathway, and everything that's up and downstream of those activities. So a patient needs to travel to receive his treatment, so we need to include patient transport. We buy pharmaceuticals maybe for the care pathway. They need to be manufactured, distributed, you know, prescribed. Waste pharmaceuticals need to be disposed of, and you need to include those. The biggest issue, I think, or the challenge we have when we're talking about doing life cycle assessments, and people say, well, where do you stop? Because otherwise you'll end up modeling the whole economy. And this is where the materiality bit comes in. And I have to say, a bit of common sense. You know, we don't need to include the paintings on the wall of the waiting room. You know, we don't have to look at, you know, who painted them, that type of stuff. And the guidance gives quite clear instruction on how you conduct a materiality assessment to decide what you include within your assessment, and how you go about essentially appraising materiality. So once you've designed drawn your map of what the clinical care pathway looks like, and you've got all the activities associated with it, that's when the hard work starts. And essentially that means collecting data about actually trying to quantify every one of those inputs and outputs from your pathway. And then I think, though that is challenging in itself, I think the next hurdle is to overcome is actually identifying data that allows you to characterize the environmental impact of every one of those inputs. And what I mean is, okay, we buy 10,000 inhalers, so that's the quantity, but what's the environmental impact associated with manufacturing that inhaler? Where do I get that information from? So the guidance provides some help in that, and there's various places you can go to get that data. And I guess that's where it falls down, where things can people to get into more difficulty. But there is a lot of data out there, and it is signposted within the guidance documents, and there is help that we can be provided, especially through things, organisations such as the coalition itself. So when you've got the quantity, the impact per unit, you multiply the two together, and hey presto, you've got your footprint of your care pathway. It is something that could be done by, a research student in 3 or 4 months. It's a fairly manageable task. They'll get a long way through the process. They may have to make estimates and assumptions, but they'll get some real learning from such an assessment. So it is something that can be done pretty readily, and I would encourage people to have a go and to have a look at the guidance. Here I give an example of the knee surgery care pathway assessment that was completed a couple of years ago. This was looking at Care for Today, which is about enhanced recovery of improving the recovery of patients who have had their knee replaced. And obviously this Care for Today system required resources to be expended in terms of educating the patient, giving them CDs, DVDs, online training, various things, and that all had an impact. And the question was whether the impact of that additional education, enhanced recovery, outweighed the benefits that were delivered. And in terms of the environment, what we found is that the benefits outweighed that investment in resources. And in fact, in the care pathway itself, we saved 50 kilos of CO2 per patient. And when you extrapolate that to 70,000 knee surgeries happen every year, you're talking about 4,000 tons of CO2, which, I don't know, is about 2,000 return flights to the US. It's not an insignificant amount. And this is one care pathway, a relatively, I won't say minor intervention within the care pathway, but it's not a massive innovation within the care pathway, yet it's leading to quite significant reductions. And it also, the guidance provides some useful data to help you. When I talked about materiality earlier, part of a clinical care pathway might involve 10 GP visits, might involve, an outpatient visit, a surgical procedure, whatever it is. The guidance provides you with, for these common sort of activities, sort of some average data in terms of what the scale of impact is from those activities. And that can help you judge the materiality of your care pathway without actually gathering any data. All you need to know roughly is, what the level of activity is around this, and you can get an idea of what a care pathway may look like in terms of its footprint. So some really useful data in the guidance. Recommend to have a look. This data has obviously been used in the calculator that Fiona mentioned, and so it allows you to play around with numbers. You don't have to pick up your own calculator and do them. So for those common activities, the guidance goes into some detail, and both in terms of how they're appraised, what was included, and what the contributions were. And so it also gives you, it doesn't just give you those headline numbers in terms of what the footprint of a, an hour of surgery is. It all tells you what the hotspots are for an average surgical procedure. So we can see here that yes, anesthetic gases are reasonably significant, over 50%. But next on your hit list are the consumables, and then the energy that's used in surgery. And for the other modules there, you get a similar idea in terms of where the hotspots are for certain activities that you're sort of common to care pathways. I'd like to make a point here that we're talking about 1,000 innovations across all the care pathways that there are will deliver millions of tons of CO2 savings. And we need millions of tons of CO2 savings. We have the NHS footprint at 30 million tons, and to get down to net zero, we are talking about thousands of innovations and reductions across the piece. There's no one component of the healthcare system that can deliver, or there's no one activity that can deliver the reductions that are needed. But, and this is the gap that the guidance sort of filled, and why it was developed, is essentially we need a consistent basis on which we can appraise the footprint of care pathways and allow people to understand what the return will be for their investment in terms of reducing the footprint of care pathways. And that's what the guidance provides. It provides you that consistent basis. It takes a holistic approach, a life cycle approach, and it essentially avoids that burden shifting, that offshoring of impact which the UK economy has done over the last 30 years. That's what we're aiming to avoid. That's what the guidance helps you do, and that's why a life cycle approach is important. And we've already mentioned the calculator is helping its use. The coalition is obviously engaged in a number of care pathway assessments, but it's a handful. We're just starting one on renal care pathways, Newcastle hospitals. We need more to be done, and we need more innovation. And the coalition is, as Fiona said, is keen to collaborate and help, and industry is there keen to help clinicians understand what the impact of their care pathways are and look for opportunities to reduce. So I think I'll stop there.
Good. Well, thank you very much, Michael. So an encouragement to everybody to get out and measure their clinical pathways and reform them and both improve patient care and reduce carbon consumption. Right, and one of the best examples of this is from Anesthesia. So now over to Tom Pearce, who sits on our executive and has done some wonderful things. When we heard this presentation, I thought you all needed to hear it too.
Why, thank you very much. Sustainability at the Royal College of Anaesthetists. I'm just going to, if I might, just describe this almost in a chronological fashion. And I'm going to start at the beginning. And the IPCC and the Kyoto Protocol identified nitrous oxide as a greenhouse gas with a global warming potential around about 300 times that of CO2. We use nitrous oxide. And on the strength of this, and in the early part, and in 2009, the Association of Anaesthetists held a meeting. And the meeting was entitled The Anaesthetist and the Environment. And whilst I can remember one or two of the items that were discussed, the thing that struck me more than anything is that those individuals who are still involved with this area were present at that meeting, including David Pension. A year or two later, in two publications, one in 2010 and one in 2012, various authors identified these molecules here, which are our mainstay of inhalation anesthesia, as being global warming agents. Sevoflurane has a global warming potential of 130 and desflurane of 2540. And what that means in essence is that when we fill a vaporizer with this agent here, sevoflurane, and we use the entire bottle, we have added the warming effect of just shy of 50 kilograms of CO2 to the atmosphere. Use this and we're closer to a ton. And to put that in context, a ton of CO2 is the amount of CO2 liberated on average in the UK by the average car commute in a year. So these are powerful agents. So the early years followed, and the president of the Royal College of Anaesthetists, J.P. Van Beschu, at the time appointed me as the environmental advisor. I was honoured. What did I have to set down and do? Well, the first and foremost was to decide my role. Well, first of all, it had to be educational. And we were able to put together what we knew about anaesthetic agents and their environmental impact in one of our educational journals. It's been widely read. But meanwhile, the college were busy trying to establish sustainable practice inside their structures. And the first structure that we attended to is a document called the Guidelines for the Provision of Anesthesia Services, or GPAS. And this is a rolling document that gets updated very regularly and essentially describes the characteristics required to deliver safe anesthesia, not just in terms of drugs and equipment, but staff, ancillary personnel, and so on. And in the 2016 version of this document, there was included the first steps of sustainable anesthesia practice. The importance of the guidelines for the provision of anesthesia services is it forms the manual by which hospitals and specifically anesthetic departments should follow if they wish to receive a really high award, that is to say, the AXA accreditation for the quality of the services they provide. The two are linked together. Whilst that was happening at the college, I felt that it's really pretty much important for us as practicing anaesthetists to try and be able to define what we do. And there are just 3 little calculators that an individual anaesthetist can do. The first is a departmental one, the second, a real-time calculator, and the third, attempting to model the whole anaesthetic. I'll take each in turn. This is embedded inside the college website, and in essence, downloaded, the individual anaesthetist would insert into the various cells the cylinder gas return data from the medical gas supplier, be that BOC or indeed Air Liquide. And at the bottom here, if we can enter the number of bottles of anesthetic vapor that are used over a time period, in this case 1 year. And it produces a pie chart and a figure. 2,500 tons was our department's carbon footprint of our scope 1 vapors that we used in the year 2019. And I want just to show you that a very significant amount of that is due to nitrous oxide. Okay. These ones up here are our volatile agents. This one's nitrous oxide, and this is the nitrous oxide component from Entonox. The second one was something that is downloaded as a smartphone app. And I just want to demonstrate, if I might, it's designed to look like the front of an anesthetic machine with flow meters over here and vaporizers over here. And if, for example, an anaesthetist was to run an anesthetic using 0.5 litre per minute of nitrous oxide through a circle system, that would have the carbon dioxide equivalents of 16 kilograms of CO2 per hour, the equivalent distance of traveling about 100 kilometers in a small car. Not unusually, and you've seen from the last slide that we don't use much nitrous oxide nowadays. We tend to use volatile agents. And the carrier gas mixture is often an oxygen and air mixture. So here's a total fresh gas flow of 1 litre. And we add to this the very similar amounts of agent required to achieve the same depth of anesthesia. This is isoflurane, that's purple, color-coded purple, sevoflurane, which is color-coded yellow, and desflurane. And you can see 1 hour of anesthesia with these agents contributes from as little as 1.3 to as much as 61 kilograms per hour. The device also puts in the cost and the distance traveled. But I've attempted to go one stage further, really, to try, if I can, to define the carbon footprint of the things that we can modify in anesthesia practice. In other words, the technique of anesthesia that we might choose to use, or indeed our behaviors once we are in that operating room. And I'll share with you this image. This is derived from the calculator that I've spent a lot of the summer trying to come to grips with and refine. And I wanted just to show you, first of all, this is for one modeled patient having a total knee replacement. This is if that anesthesia is given using desflurane, 138. If that same anesthesia was used with nitrous oxide and isoflurane, it would come out at 58. But this perhaps is a bit more typical, sevoflurane and oxygen in air. But we don't just have to limit ourselves in clinical anesthesia practice to volatile agents. We can use total intravenous agents. And in this little bar, I've just showed what happens if we switch to a total intravenous anesthetic. Perhaps many of you have seen patients who've had their knees replaced under a spinal anaesthetic. And I've modeled that in this bar here, and it comes down to 5.6. Now, if we then stayed at that point and gave a spinal anaesthetic, and we said, well, what could I do to try and minimize or reduce still further the carbon footprint of one's anaesthetic? What about if I turned off our wasteful anaesthetic scavenging systems out of hours? Well, that reduces the carbon footprint still further. What about if that waste that we generate now goes to an energy from waste facility? That reduces it still further. And what if we discarded the car and cycled to work over 10 kilometers? That would be the impact on that patient's carbon footprint of their anesthesia. So in other words, we can change not only the agents we use, but also our behaviors when we're in the clinical environment. Now, this has not been without help from a considerable number of other people, this journey. Centre for Sustainable Healthcare have been fantastic in bringing together this and producing our fellow programme. And this in conjunction with the Association of Anaesthetists and Newcastle Hospitals NHS Trust. The first incumbent was Kathy Lawson, and the second, Chris Allen, who took over just in September of this year. And their work has really galvanized the interest amongst the younger anaesthetists in our country. The strategic development at the college mustn't be forgotten. And one of the things that really was very, very useful at an early stage was that me as the environmental advisor had direct access to the college council via a dedicated member of college council, Lucy Williams. And she was the driving force behind the sustainability strategy and the entries in sustainable anaesthesia practice that went into our new quality improvement recipe book. But what I really wanted to try and achieve was to embed sustainability within the curriculum. And we've been very fortunate that the curriculum goes through 10-year rewrites. And the rewrite for 2020 will probably be published in 2021 and is based around higher learning outcomes. And the great advantage of this is that aspects of sustainable practice can be built in at multiple levels. Sadly, the major textbooks on anaesthesia practice all came out as new editions this year, so they're unlikely to be replaced until for 5 years or so. If we wanted to introduce anaesthesia or sustainable anaesthesia, particularly in the examination curriculum, then we would need some learning resource. And it was that, with that in mind, that Kathy Lawson and myself, we commissioned and have edited our series of e-learning modules, which were published on the college website in the last week or so. They're written with anaesthesia in mind, but they also contain a lot of material that is applicable to other disciplines. The seminars programs from the word go have been absolutely vital. I mentioned the first one that happened in 2009 at the association, and we've had a series of seminars since. The Scottish Environmental Anaesthetic Group held one also on the association platform in September. And this week, Lucy Williams hosted a sustainability seminar, a webinar on the Royal College platform. And within the college website and our close relationship with the BJAA, our sustainability documents and our sustainability strategies are available at this website. And I have to say that this particular article, which is due for publication, I think in November's edition of the British Journal of Anesthesia, written by Forbes McGain in Australia, Jane Murray in France, Kathy in this country, and Jodie Sherman in the United States, is an absolutely fantastic, up-to-date synopsis of all the components that go into creating the carbon footprint of our anaesthesia practice. And the pathway ahead. Well, both of these documents, the NHS long-term plan from 2019 and this document here, published just at the beginning of this month, specifically mention anaesthesia gases as areas for us to concentrate upon. Now, that pathway ahead may be influenced by us as practicing anaesthetists, but I think we have to remember that a lot of what we've achieved, we've managed with our association and our work with the industries. And those industries have been the anaesthesia machine manufacturers, but also we must think about opportunities to potentially capture exhaled anaesthetic vapor, reprocess it, re-refine it, and re-deliver it to subsequent patients. And that's technology that's being developed by Sage Tech in this country. And within the world of catalytic destruction of nitrous oxide, there are catalytic converters. This is a small one designed for use in an office facility, mainly the United States. But there's no reason why this can't be upscaled for the inclusion on the top of a new build and harvest that nitrous oxide that comes out of the delivery suite, which I've indicated already is top of that list. And I've shared this with our group, the small breakout group, that within the last week, we have now started to engage with our patients. And the first gentle foray into that was the production, with the help of the team that produced at the college, our patient information leaflets. And this particular leaflet, entitled Your Anaesthetic and the Environment, introduces for the first time the variation in the carbon footprints of anaesthesia for various procedures. So in summary, the journey has been driven from the top, driven from firstly international organizations and then subsequently from the president of our college. There's been collaboration at all levels inside our college, and we've managed to engage with clinical anaesthetists throughout the land and throughout the 4 nation states. There is, and I have noted this over time, this has moved from fringe to mainline thinking. There is a real groundswell of enthusiasm. And I think that enthusiasm is there to help deliver that net zero NHS from the anaesthesia perspective. Let's not forget the involvement of science and technology in helping us achieve that. And I would love it if our patients could be part of that decision-making process and we could have proper consent and proper informed consent that would add to the improvement in the environment that we all strive for. Thank you all very much.
Brilliant.